Good afternoon, everyone. Thank you for being here today to take part in our October session of the Global EM Fellowship Conference. My name is Nico Risco. I'm Associate Director of the Johns Hopkins Center for Global Emergency Care, and I'll be your moderator today. It's my pleasure to introduce not one, but two exceptional speakers for our session topic of decolonizing global health. Today, we are joined by Dr. Stephanie Garbern, Assistant Professor of Emergency Medicine and Research Coordinator of the Division of Global Emergency Medicine at Brown University. Welcome, Dr. Barber. We also have Dr. Catalina Marqués, Instructor of Emergency Medicine at Harvard Medical School and Brigham and Women's Hospital. She is also Associate Director for Emergency Health Systems at Harvard Humanitarian Institute. Welcome, Dr. Marqués. I should note, Dr. Marqués is joining us from the airport prior to deploying to Ukraine. So she may not be able to stay on for the whole session, but Dr. Marqués, I think I can speak for everyone here when I say we appreciate what you are doing, and we're very thankful for the extra effort you have made to try to be with us today. So I will go ahead and pass over to our speakers.
So hi, everyone. There might be some background noise, but we're going to try to get through this as much as possible. We're going to kind of speed through the didactic part because we have found every time that Steph and I do this, the really kind of most interesting part is when we have a lot of discussions and you all get to talk more about your experiences and kind of things that you've recognized in your work. So I guess we'll just dive right in. And again, sorry for the background noise. There's an announcement going on at the airport, but and just kind of go through a brief didactic. And then again, we really are looking forward to talking with you all. So just a few ground rules, as you know, all of us possess positions of power and privilege, but also times where we lack power and privilege. And so just be present and be aware of that in the discussion. We really ask for clarification if you don't understand something. This is not, we are not experts in this. And that's one thing that's very clear to us. We're just facilitating. And I think it's important to acknowledge that, Steph and I work in high-income countries by practitioners, and we're practitioners with ties to academic institutions. And we, have come into this with our own biases, even as much as we try to get through this. And of course, we always just ask for respect. So diving right in, this is just us, but that's what we actually look like. But going on into the history, I think Nico already gave us a great introduction. Thank you so much for that. So it's really important to recognize that the history of global health and actually medicine actually has some very racist and colonial roots. So to colonize means to kind of settle, establish control over, conquer, dominate. And it really aims to remove power from people and dispossess them, transfer resources, kind of in the name of things that civility or progress. And colonial medicine was actually a really critical element of conquering lands, especially in imperialism throughout the world. And the truth is, when you come down to it, the goal was really to protect European health and European interest, maintain military superiority, and really just support extractive industries. And when we even look at the things that the medicine was claiming to look at, they held very narrow approaches, really to protect white men in the tropics. Well, if Rick is going to be 70, we can go on to the next one. He'll be 70. Yeah, he'll be 70 before. And so this is actually what's now the New England Journal of Medicine, so the Boston Medical and Surgical Journal. And you can see that, I don't even think they were trying to hide here. But, the way that medicine was described and global health was described was the conquest of tropics for the white race. And even the Gorgas course, which is taught, Gorgas actually has some very racist theories and practices. No, we can keep going. So global health, this is from an article from Richard Smith that kind of talks about how he parsed out global health. And again, I'm so sorry, there's a lot of noise pollution here. But, we kind of have this global health 1.0, which is tropical medicine. So again, where we said that we're going to use medicine, but really we were using it to conquer and to keep white men alive in other places. And then we move on to Global Health 2.0, which is kind of like this international health, where it really was clever people in rich countries doing something to help people in poor countries. And then Global Health 3.0 was kind of like where researchers kind of got onto this and caught onto this and then started leading research programs in other countries, but in ways that were quite extractive. And so the question is, where can we go from here in Global Health 4.0? But the thing is that in order to kind of go forward, we have to recognize that we're still quite colonial today. And so, I am very open about some issues where I work. So, but it's true. And this is from a Say Ambibola article where he very astutely points out that more leaders of global health and research organizations are alumni of Harvard than are women from low and middle income countries, who are the people who actually do the labor of global health and who experience what we call global health on a daily basis. And when you look at research agendas and who they're funded by, and they really get to make the decisions and dominate, but it's really high income country experts and people like the Gates Foundation, USAID, with very little input when they're setting and driving the agenda on behalf of people, but really without input or recognizing the incredible local expertise in projects. They come on as afterthoughts in grant planning, in project planning. And so there's been some great articles that I've actually looked at them. And one of them is by Chris Rees, and it looks at parity or parasitism in publications. So when we look at research and we look at first and last authors from high income countries, you'll really realize that even in research that's done in low and middle income countries, we're not giving those authors that local expertise their credit. And so I'm realizing we should actually probably update this with our study where we actually looked at global emergency medicine literature to see where we are, and we actually weren't doing that great. Global emergency medicine literature done in low and middle income countries often does not have first or last authors from those countries. The other thing I think that's important is that publication and open access fees aren't insignificant and are often way more than someone makes in a year, and create all these barriers and all these gatekeeping to publication. And the language of the literature still kind of imposes Western standards on our colleagues in other parts of the world, and still writes about our colleagues in other parts of the world in a language that's really deficit focused. I think other ways that we can point this out is only a third of editors of global health journals are actually based in low and middle income countries. And we often only publish in English or in French when that's not the native language of the places in which we work. And so when we look at education, and this is being self-critical of our own education, is that there's really a lot of problematic short mission experiences, right? And you really have to think about what happens to the community after you leave. And even global health fellowships and degrees are really only available in high-income countries for high-income country students or trainees, and at prices or at fees that really none of our colleagues would be able to afford, and often are even barred from applying to. There's also a ton of lack of reciprocity in how we do educational opportunities. So it's often high-income country learners going to low and middle-income countries. Just the opportunities are not in reverse. There's really no opportunity for exchange or for them to come to a high-income country and gain experience. And I think some of the ones that we don't always like to talk about, but I think a couple of us have seen, is that people who may be at the resident level or at the medical student level performing procedures that they would never be able to do unsupervised in their home institutions. And so when we talk about what this actually means for global health, and this is actually this very problematic line that was drawn, it's called the Brandt line. It's getting away from this. It's not a global north or a global south. And if we go to the next slide, it's what does this movement kind of aim to do? The first thing is to weed out Western biases and approaches. We're stuck in this mindset of West is best. And it's really to start addressing pervasive power imbalances in representation, but also in resources. Really asking the question, are they really resource limited countries or resource denied? And it's deconstructing these colonial ideologies of superiority, Western and white privilege thought and language and approaches that are still really pervasive in a lot of the power structures that we actually work in. But most importantly, it's really about revitalizing local knowledge and approaches and indigenous approaches and indigenous knowledge and those values that may be very different from the ones that we hold, and restoring that power and control to those places that have been colonized. But again, and this is something that's really important that Steph and I always like to say, is that we have to recognize that the leading current academic voices of decolonization are products of the colonization themselves. They're not that far apart. Yeah, like that next generation. And so again, the reason that we talk about this and we do this is because we really have to think together as a global health community and like an emergency medicine global health community. How do we look inwards at this uncomfortable legacy and set a new legacy? We have to start questioning, but also weeding out the persistence in our practices today. And it's an important question to ask: is our work replicating inequities of the past, which will lead to persistent inequities? Are we actually doing more harm? So the next slide. I now hand it over to Stephanie, and you will have much less noise pollution from the airport.
Thanks, Catalina. So basically our next question is to ask, so we've identified the problems, but what is actually our path forward? And so what Catalina and I work on in our spare time is basically trying to come up with some sort of a way that we can actually act on these changes that we've identified. And many other groups are trying to do the same as well. Outside of the emergency medicine field. But a lot of changes needed for who drives the research agenda, as we mentioned, who dominates authorship, who holds leadership positions and gets recognition for a lot of this work. And regarding, the research aspect, as Catalina mentioned, who edits the research, because those people are often the ones that really control what gets published. And then lastly, who gets educated and how. So when talking about how we actually make change, the change comes in many different forms. There are both changes that we all need to reflect on and really make as individuals who are global EM and global health practitioners, and then also larger changes that need to happen at a more institutional and a much broader level. We're hoping that we might be able to examine some of both of these components today through some of the exercises that we'll get to actually very shortly. But when we talk about changes within individuals, a lot of what we're really talking about is kind of just this concept of really leaning out. So amplifying the power and leadership of those from low and middle income countries, also examining how we talk about the work that we do that's in lower middle income countries, and really shifting from this lens of being a savior to a supporter. Actually, a lot of what we do in decolonizing global health, as we've started to work in this field more and more. And I think as we're hoping all of you will also, I know a lot of you have been working in this field, but also continue to throughout your careers. We're hoping that this becomes something that you look at, with all of the work that you do in developing your career in global emergency medicine. Just yesterday, actually, there was like a medical student that I work with who's from Uganda, and he sent out like this email. Some of you might even be on this email chain, like asking for basically financial support to attend the AFSEM conference in Ghana. And actually, when I looked at like the amount of fees that it would cost for him to like go attend and like present multiple great abstracts, it was such a small amount, and so small of an amount compared to what we fund multiple students and residents for summer electives, for rotations. And it really just begs the question, like, why is this something that is so rare for a Ugandan medical student to be able to go to an international conference when it's something that's so common for even an undergraduate student from the US to be able to do on a very regular basis. And then we talk about what are the changes within institutions. So talking about like the research, the educational projects that we work on, how can we increase the use of local expertise and resources? Questioning, times like, do I actually need to spend $2,000 on a trip to go for 2, 3, 4 weeks somewhere when there might be someone that's probably much more of an expert on a certain topic that could do the same research or educational project? And then designing projects and studies that are led by local researchers, local EM clinicians from the beginning, and making sure that when we create projects, these are not being led by people, in these academic institutions, typically in North American or high income institutions, and how we can change this. And this is a great quote from a physician actually at the University of Michigan. She's Ethiopian, and she just says, "We're all part of a broken system. Doing good work in the field requires taking a critical eye to one's own identity and how one has benefited from a system that oppresses so many others." So we are now going to go to an exercise. So I think I put in the chat, but I'm going to put it in here. You should be able to see it in the chat if you want to download this exercise. So the first exercise that we're going to do is actually really about individual reflection on our personal identities and privilege and how this might impact our global health work. And I just realized I spelled privilege wrong. So if you want to go ahead and download this, you don't have to download. I'm going to put it on the screen next as well, but it's I found it helpful to actually put in some of your responses. So go ahead, click the link in the Google in the chat if you are on a computer. If you happen to be on your phone, I will also put this up on the screen, or if you are driving, you also please focus on your driving. I will try to do a verbal narration of what the document is. This is an exercise that's adapted from the GHERD curriculum, that stands for Global Health, Education, Anti-Racism, Equity, and Decolonization curriculum. And that's a wonderful curriculum. If you haven't heard of it, it's really focused on decolonization, but also other concepts of anti-racism and equity. And it's created by a bunch of providers, a bunch of pediatricians from the American Academy of Pediatrics. And it was launched earlier this year. And Catalina and I and the Decolonizing Global EM Working Group of SAM have been collaborating with them to create more modules related to kind of non-pediatric content. But this is just an adaptation, a very truncated version of this. And the purpose of this exercise is to examine how do aspects of our personal identities overlap to create new and different amounts of both discrimination and power. We all have aspects of our identities that both put us closer or further away from power and privilege in society. And that also will change depending on if you are in the United States, or if you're in Europe, or if you're working in whatever site that you work in, doing your global emergency medicine work. The purpose of this exercise is to help reflect on our identities and how this can give us different amounts of privilege in different settings, especially in our global EM work, working with vulnerable populations. So this is just a chart. So I'm just going to give everyone like 3 minutes, and everyone you can either do this on like your actual computer, or you can just mentally do this. And Matt, I can verbally read this out for you also. So this is just a chart showing how different domains of our identity can give you either privilege or marginalization compared to the other people that are in this setting. So we have a few different identities, and this is much more extensive in the full length version of this exercise. But we just looking at a few of them to see how your identity may be shaped by where you are now, for instance, for those of you who are working in like a North American academic institution, and then the places where you do your global emergency medicine work. So those domains that we have here are listed are: what are your race, your ethnicity, your skin tone, your gender identity or gender expression, the level of education you have, your socioeconomic status, your physical condition, which includes any disability status, your citizenship status or statuses, and your first language. So I'm just going to give everyone a few minutes, let's say until 4:24, to fill out this table. You can fill it out on the document downloaded, or you can mentally do it just looking at this screen. And then we're going to have everyone divide up into small groups to do some brief reflection on this with some additional questions. And I'll also just take a pause here as you're all filling this out to also be able to answer any questions anyone may have. All right, welcome back, everyone. Sorry for the lack of screen sharing. I meant to actually put the questions up that would be displayed in the small groups. I listened in just on one of the groups as I popped in, and it sounds like the conversation was really fascinating. So I was wondering if someone from each room, we're just going to spend 5 minutes reflecting on some of these questions that are listed up here, but if someone from each room could summarize what you talked about, and maybe identifying, how the different identities that you had in your group you have found that this influences your work, whether that's in the North American context, where you're doing your current clinical work, or from your global emergency medicine work.
I'm just turning the recording back on so they can see these questions if they're watching this later and want to reflect them on their own. Thanks everyone for your time. We really hope you got something out of it and that you enjoyed it. I think we all recognize that we have a really long way to go, but there's a lot of common themes and a lot of steps that we can all take individually, but also kind of in our work and hopefully at the institutional level where things are harder to change. It doesn't mean it's impossible to change.
Thanks. Yeah, and I just want to emphasize that the point of this work, and we're hoping that all of you are as excited as us about making change. The answer is definitely not to stop doing global emergency medicine. I think I always am afraid that people are like, oh, we're doing terribly, we should just go into a different field. But it's actually not to stop the work that you're doing, but just to think about how we're doing it and make changes so that we can support and really lift up the collaborators that we have. So please let us know if you're interested in learning more. We put our contact information here if anyone wants to get in contact with us, or you can also reach out through Nico and Linda, I'm sure. And yeah, if you're interested in doing some of this teaching on your own in your own institutions, please also let us know. Have a great afternoon, everyone.
Thanks, everyone.